I'm going to be talking about the use of point-of-care lung ultrasound and acute respiratory failure. I have no financial disclosures. My main disclosure is that I am I work in a intergalactic trauma center in the United States, so I don't have a tremendous amount of bedside international experience, but I think this is a really important topic, whether it's in a setting where you have all the bells and whistles and all the resources available, or even perhaps more important, in a resource, a developing setting. This is my Twitter handle and my email account. So if I don't do a good job, I want you guys to send me an email, okay? So I can explain to you. I think this is really a revolutionary way to use a revolutionary tool. As I was getting on the plane, I was looking through my email and I saw this really interesting article in the Blue Journal, it's a critical care American journal, looking at ARDS in Rwanda. And it was sort of an eye-opener. And one of the conclusions in the article, or one of the findings, was that half the patients in this particular hospital who had low oxygen saturation didn't get a chest X-ray. And that's sort of, wow, that's something that we would, just click a button and the magic chest X-ray fairy comes and swoops right in. Apparently, there are a few burdens and hurdles that need to be overcome. First, the doctor needs to think that it's necessary. And in some cases, if you have a clinical exam, perhaps it's not necessary. Second, the patient has to be actually able to afford the test, which is sometimes a huge barrier. And third, you have to have a machine that's working and available. Now, after this lecture, I hope you can understand, and I hope I'm able to explain where lung ultrasound can certainly play a role in the management of acute respiratory failure. Lung ultrasound is probably, definitely better than chest X-ray. It's probably even as good as CT for the right cases. So just how many individuals here, how many people have ultrasound devices in their hospital? Okay. And how many of them are not locked away in the radiology department? They can actually get to that ultrasound machine and use that ultrasound machine to take care of each device. Okay. So a couple hands go down. How many of you guys actually use point-of-care ultrasound to take care of your patients? Okay. Lung ultrasound? Okay. If you're doing lung ultrasound, are you doing it just for pneumothorax diagnosis? How many people are doing just for pneumothorax diagnosis? Okay. And how many people are doing it for more complex diagnosis, like looking for pneumonias, pleural effusions, looking to sort of correlate hemodynamic status, wedge pressures? Okay. So each one of those, after I ask each of those questions, the numbers go lower and lower and lower. And lung ultrasound can seem very intimidating because it's very counterintuitive compared to other ultrasound means. When we do an ultrasound of the heart, we actually look at the heart. The pictures we get kind of look like what we would think the heart would look like. When we look at the aorta or the gallbladder, it looks like an aorta or a gallbladder. When we look at the lung ultrasound, it doesn't look like what the lung is supposed to look like. Lung ultrasound is an ultrasound of artifacts, and that can be intimidating. But hopefully, I can explain to you a better understanding of what those artifacts mean, because those artifacts are reproducible. Okay. So the main point of this lecture is I want you to think about air and water. Okay. Just think about the beautiful time that we've all had in Cuba, looking out at the ocean, seeing the air and the water. That is what the artifacts correlate in lung ultrasound. The amount of air to water will give you a classic definitive signal that you can correlate to pathology. What does that mean? As you start off with all air in the lung, that gives a definitive signal. That gives the A-line signal that we see. All air, that would be actually pneumothorax. As you start to get more fluid in there, you start to see pleural saliva. That's normal lung. As you get more fluid in the lung, they start to fill, you get the cocktails of the V-lines. As the lung starts to consolidate and fill with even more fluid, you get that characteristic tissue appearance pattern. And as you get just fluid, now there's no more lung, that's a pleural effusion. But it also gives a characteristic pattern. So as you go from air to fluid, that will give a definitive characteristic artifact that you can use to help diagnose your patient with acute respiratory failure. Okay. So we take care of sick patients. We are, I think you guys are superheroes, taking care of critically ill patients. So, think about being Batman, channel your inner Batman when taking care of your sick patients. What do I mean by being Batman with lung ultrasound? So the first key to lung ultrasound is actually make sure you're looking at the lung. So the first key is finding that bat signal. Okay, it's like in the movies with Batman, the bat signal in the sky. Okay, and that bat signal is going to be your two rib shadows. Okay, those are the wings of the bat, and the body of the bat is going to be the pleural line. It's important to find that bat signal. If you don't find that bat signal, you may not actually look at the lungs. That can make it confusing. Okay. What does normal lung look like? What does that air artifact look like? Okay. So you're going to have the distance from the probe to the pleura. That's going to be your A-line artifact. So you can try this at home the first time. Take your ultrasound probe, put a lot of jelly on it, and point it to the sky. Okay. You will see air. You're looking at air. You will see those horizontal lines on the screen. That is the distance that the probe has to travel to the air. That scattering will be your A-line artifact. And each of these artifacts will be at the exact same depth. That probe depth will be your air. Okay? If you see this, you're looking at air. You're doing an aortogram and you're in the abdomen, you see this, you're looking at air. That is what air looks like. However, what's also important is not just to look at the air, but also to look at the pleural line. Make sure you see that shimmering. Okay? Because if you're just seeing air, you might be dealing with a pneumothorax. So just seeing A-lines is not enough. A-lines are usually normal, but if you see A-lines without sliding, you might be dealing with a pneumo. Okay. Here's a nice example. So, okay, this is a linear probe. Okay. What do we see? No sliding, right? You see the A-lines, same distance, probe, or no sliding. This potentially could be a pneumo. Okay. A short word on probes, because this is always a great ultrasound controversy which probe to use. If you're just looking for pneumothorax, if you're just looking for superficial structures in the pleura, the linear probe is probably sufficient. The linear probe, as you're probably aware, has high frequency, has high resolution, but has low penetration. So for superficial structures, that's the way to go. However, if you want to look for everything else, you want to look for your B-lines and your other common tail artifacts, if you want to start taking an all-in-one approach, I like to use the phased array probe. Some of the big names that recommend the microconvex probe, I just don't happen to have that. Really, any probe used correctly can be used to look at the lungs. If I'm doing a rush, if I'm doing an echo or a fast exam, and I want to look at the lungs, I'm just going to take that probe and switch on. Okay. So the linear probe for pleural-based disease or pneumothorax, a phased array or convex probes for everything else. Okay. A-lines we talked about, and again, it's not just that horizontal artifact you want to look for. You want to make sure that you're seeing that sliding, because if you're not seeing sliding, chances are you're just hitting the air. Whereas here, you can see that sliding gives you that artifact. Okay. So that's all air. Let's put a little bit more fluid into the lungs. This is a really important concept right here. This is the B-line. This is the common tail, or the common tail artifact. Now what happens with B-lines? So you have alveoli here, and these walls of the alveoli are very thin. Sort of in the normal individual, they're theoretical spaces. They're infinitesimally small. The ultrasound beam doesn't really ever come in contact with them. And what happens is the ultrasound beam hits the air and reverberates, bounces back, scatters, and you get that alien artifact. As you start to fill the lung up with fluid, and as that alveolar septate starts to thicken, this theoretical space actually turns into a real space. Now that it's thick, the ultrasound beam can actually hit that space. And when it hits that space, you get obliteration of the A-line. And instead of seeing a horizontal artifact, you see a vertical artifact coming down. Now what causes the B-line artifact? For that, you have to be a clinician. You have to take the clinical context into play. Just as you would see pulmonary edema or curly B-lines or ground glass opacities on a chest X-ray, you need to take that into clinical context. Okay, so if a patient had fever, and was coughing, had turbulent sputum, those B-lines might represent a multifocal pneumonia or pneumonia. However, if you here, the B line's getting more increased as you're going further down the abdomen. It looks like it's gravitational. That will point to a more cardiogenic or high-fat pulmonary edema picture. If it was a trauma patient, sometimes they say someone doing a fasting attempt, did that patient just aspirate? Do they have a pulmonary confusion? Okay, so those are other ways for B lines. I remember in medical school, during my pathology classes, being taught about hepatization of the lung, where my professor would show me this lung tissue that had been consolidated and infected, and it turned out, it looked like, instead of being this very light and fluffy material, the lung actually looked like the liver, and that was called hepatization. Well, we can actually see that with the ultrasound. So the lung goes from a very nice airway structure. Something is blocking a bronchus, you're getting pus, it's the alveoli are filling with fluid. That actually will look like tissue. And you can see that where the tissue, you can actually see lung tissue. And it actually looks like the liver. Now it's important that you're not actually looking at the liver. Sometimes I'm fooled, especially when my patient is supine. I put the ultrasound probe on and like, oh, that looks like the liver. It really is the liver because the liver is sitting high up in the chest. So what you need to do is you need to make sure you go down, you find the kidneys, and then you work your way up. Kidney, liver, diaphragm. You need to make sure you're looking above the diaphragm before you say that, oh, this patient has a consolidation and pneumonia. Okay. Finally, fluid. The ultrasound's pretty good looking at fluid. And the pleural effusions are pretty easy to see. This is a tongue sign, and you can actually see the lung floating in there. It looks like a tongue. As opposed, and this is a consolidated lung, either consolidation or atelectasis. As opposed to this fluid here, this pleural effusion, and here we see B lines. That lung is a little bit more aerated than that one. You can actually look at the fluid and sort of get an idea whether you're dealing with a transudate or an exudate. So if you have a fluid structure that's very dark and not a lot of signals in it, that's more likely not a transudate. If you see sort of what they say nighting, or you see like schmutz in the fluid, if you see high signals in the fluid, that could be blood, or that could be an exudate. So in the right clinical context, you have someone with a fever and pneumonia, and you see an effusion with these complex signals in it, you might be dealing with an emphysema. That patient might be in chest tube. So this is important. And I'm going to show you some case studies that shows how this has changed my practice at the bedside. Putting this all together, one of the preeminent intensivists in France, Dr. Lichtenstein, came up with a blue protocol. Serially looking at these 6 areas of the lung, 2 anterior on the chest, and 1 laterally on both sides. And using this blue protocol, trying to figure out what the diagnosis is in acute respiratory failure. And this is something that can be done at the bedside. This is something that if you're well trained can be done in less than 5 minutes. And you can increase your accuracy, and you can be 90% accurate to diagnose what's going on with your patient. This is based on the following sort of levels. Is there lung sliding? Is there a B line, A line, or a mixed profile? And then if there's nothing, you have to look for something else. You have to look at the heart, you have to look at the heart. So let's go through some cases, trying to make this more interactive and interesting. So this is a case I had a few months ago. 65-year-old female presented with 2 days of difficulty breathing, but all of a sudden, over the last 2 hours, it got progressively worse. And she was severely dyspneic. Her vital signs were a little off, but not horrible. I really couldn't get much more history from her because she was so short of breath. So I'm like, oh, let's just put her on BiPAP, right? It's going to be COPD, it's going to be CHF, because that's what it always is, right? My resident was not too happy with me. She's like, Brian, you can't just go putting patients on BiPAP, without that, explanation. Why don't you do a lung ultrasound and see what's going on? So here's what I saw. So use a linear probe and looking on the left. Okay, see the next slide. And here I'm looking on the right. And what do you guys see? What do you think? What do you think about that thorough line there? Look here. Moving? Yes. How about here? Not moving, right? No sliding. Okay. So that could be a pneumothorax, and sort of, we know that positive pressure ventilation is probably not the best treatment strategy for a pneumothorax. So I get the chest X-ray, and I see a big pneumothorax. So instead of putting this patient on BiPAP, I put chest tube in the patient, and that sort of changed. Had a definitive change in the management and of the patient. So one teaching point for the junior faculty, sort of one of the challenges of emergency medicine is we see so much stuff and there's so much pattern recognition in emergency medicine. It's not being lulled into thinking that everything is going to be that common diagnosis. You sort of do have to look out for those dangerous, life-threatening things. So how does ultrasound compare to chest X-ray in the diagnosis of pneumothorax? Lung ultrasound blows away chest X-ray for the diagnosis of pneumothorax. Okay? So sensitivity, 40%. So I have 100 patients in a room with a pneumothorax. That chest X-ray is only going to pick up 40 of the patients. Okay? That's not acceptable for a test. So perhaps you're like, okay, Brian, why don't you just put the chest tube in right then? Why don't you wait for the chest X-ray? So this is an important point. I want to go through how you diagnose a pneumothorax with a lung ultrasound. Because it's not just enough to see absence of sliding. Okay? There's other things that can cause absence of sliding. Okay? So let's walk through this algorithm. Okay? You see lung sliding on your ultrasound, you do not have a pneumothorax at that spot. You're done. Okay? So the lung ultrasound is great for ruling out pneumothorax. Okay? All right, no lung sliding. However, you see V-lines. Great. V-lines, you do not have a pneumothorax. Right? You don't see V-lines. Okay, now you got to start to be concerned. Do you have a lung point? And I'll explain what a lung point is. That's the point where the pleura is coming into contact. The parietal and distal pleura are coming into contact. If you have a lung point, that is specific for a pneumothorax. So in order to definitively diagnose it to rule in a pneumothorax, you need to find a lung point. If you don't have a lung point, you look for something called a lung pulse. And that is when the lung is inflated, but it's not moving, and you're seeing the cardiac reverberation on the lung side. Okay? So a picture's worth 1,000 words. What is a lung point? This is a lung point here. Okay? This is where you see, in the same rib space, you see absence of sliding, and then you see the lung sliding in there. Okay? That is a lung point. If you see that, you have a diagnosis of pneumothorax. You're seeing the point. You're seeing a point during inhalation and exhalation where the lung is actually coming in contact and then losing contact with the lung. That is diagnostic of a pneumothorax. This is actually really helpful because you can use this to figure out how big the pneumothorax is. So the other point, the other air water sort of, the other importance about air and water is that the air rises and water sinks. Okay? So when you're looking for pneumothorax, you look anteriorly. So if you have no A-lines on top, and then you go down and you find your lung point, you go down inferior, and you go down laterally, and just a small distance, a few centimeters, you know that you're dealing with a very small pneumothorax. However, if you're here, and you keep on going down, you keep on going down, you keep on going down, and you keep on going down until you get pretty lateral, and that's where you see your lung point. You know that, hey, you're dealing with a pretty large pneumothorax. Okay? This is also from Lichtenstein. This is a great picture on the bottom as to why the chest X-ray is a very poor test for pneumothorax. If the pneumothorax is not lateral, if the lung is extended all the way out and it's just an anterior pneumothorax, you're not going to see that line on the chest X-ray. Okay, so this is a lung point. This rules in a pneumothorax. Here's a lung pulse. It's a little more advanced time. So you see the boom, 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 boom. You see that? That's the heart moving. And because the lung is expanded, you can actually see that heart reverberation being transmitted to the lungs. So that's a problem, because that means that the lung isn't moving, but it does mean that the lung is inflated. So that you'll see in adolescence. That you'll see in apnea. That's important if you intubate someone. Okay? You intubate someone, you're not seeing sliding on the left side, but you are seeing that lung pulse. That doesn't mean throw a chest tube in. It probably means that you main stem the right main stem and right ankle. Okay? That's a lung pulse. Okay. Be back in. Okay? You gotta find that back. Because if you don't find that back, chances are you're not looking at the lung. Okay? I'm sorry, this is just a still picture. What does this look like over here? This picture over here on the left. Those lines coming all the way down. Looks like B-lines, right? And I just told you that B-lines rule out pneumothorax. However, what's going on is that we did not find the back here. Okay? These B-lines, these horizontal lines are actually not coming from the lung. These lines are coming from the subcutaneous space. This is what subcutaneous emphysema looks like. We know subcutaneous emphysema is often associated with pneumothorax. So you need to find the bag to make sure that you're actually looking at the lung. That was a very scary picture. This happens to me all the time in this case right here. 55-year-old gentleman, short of breath, wheezing. Happens to have COPD and CHF. Have any of you guys treated a patient that actually had both of those problems? Yeah. And so my paramedics, here wheezing, they do a great job. They get him very quickly. They pound him with steroids, pound him with nebulizers. Okay. But his blood pressure is through the roof. And I hear diffuse wheezing from our guy, he's not getting better. So what do we typically do for these patients with ultrasound? In the States, we take a kitchen sink approach as we throw everything at them. They get steroids, they get nebulizers, they get antibiotics, they get nitrates, they get diuretics, they get everything. Perhaps it's not the right way to go. What if you put a ultrasound and saw that? What do you think? What are we seeing? Does that look like air? So someone with COPD would probably just have air. Does that look like an air pattern? No, that looks like fluid. Okay? And if you saw beelines everywhere, all the way up and bilaterally, that would sort of go along with the diagnosis of pulmonary edema, cryogenic pulmonary edema. This is someone we should probably put the beta agonists away and actually push for nitrates, and when they're stabilized, diuretics. And again, looking at the blue protocol, that sort of goes along with that. And here's what that test actually might look like. There's this great study by Wittgenstein looking at how does your A line or B line pattern correlate with your wedge pressure, your PA and inclusion pressure, which is measure your lymph pressure, with the caveat being that high pressure would suggest fluid overload. So if you have A lines anywhere in the anterior chest, that would suggest chances are you have a low wedge pressure. You have a low wedge pressure. So if it's distal and there's B lines, it's not cryogenic. If there's septic and pneumonia and you have A lines anywhere, you're probably safe in fluids. As you guys know, ARDS, and you can have bilateral infiltrates on an ARDS or pneumonia. How do you make that? How do you differentiate that between cryogenic and pulmonary edema? Well, there's a couple things you can look for. The first thing is, are there skip lesions? So you see B lines here, you see past A lines, and then you see B lines again. Now, if it's cryogenic, it's pressure-based in nature, it should be gravitational. So it should lots of B lines, and as you get higher up, the gradient should get lower. You should get lower, you should get less and less B lines as you get higher up. If you're seeing areas in between, it's probably not a pressure-based mechanism. It's probably either an inflammatory process or an infectious process. If you see a lumpy pleural line, that would suggest that you're not dealing with CHF, you're dealing with pneumonia or an ARDS picture. If you see B line without sliding, that suggests an infiltrate. That suggests that there's something sticking the visceral and parietal together. And you can also cheat and actually look for other things like they have pneumonia, they have an infection, etc. So, and again, that's important about the blue protocol is that you're still being a doctor, you're still being a clinician. You can look posteriorly for effusions, for consolidations. And again, if you had a unilateral pattern of that same patient, I'm seeing A lines on one side, B lines on the other, that would suggest more of a pneumonia, and not necessarily CHF infection. However, it would also suggest that their PA pressure is low. Okay. This is the awesome case that I had. Okay. 52-year-old female comes in shock, cyanotic, has JVD, sudden onset of chest pain and passed out, and I can't get a blood pressure on the patient. So with the JVD, I'm pretty convinced that there's some type of obstructive shock that's going on with this patient. So I do a lung ultrasound, and I see sliding pleural lines bilaterally. I see it. So I know that this is not an pneumothorax. Okay. So for me, I'm thinking there's two ways that this case can go now. So I put a probe on the part, and this is what I would expect from this. Let's pretend this is what I saw. Okay. This is a heart. Okay. This is an apical four-chamber view. Over here, so this is a cardiac representation. So here's the LV over here. We can see the aortic outflow. So we can hide. Here's the right ventricle right here. What do we think about this? What do we think about this echo here? On the back, what do we think? RV is dilated. Okay, so the RV appears to be the same size, maybe a little bit bigger than the left ventricle. And we know that the RV, should not be that large. However, the caveat is there's actually a lot of patients with pulmonary hypertension, so this isn't enough to say you actually have patients with chronic pulmonary hypertension, at least in the areas where there's a lot of smoking and COPD. Pulmonary hypertension is common. There's also another finding was that it's more sort of specific for PE in this particular case. Anyone see what that is? McConnell's sign. So we could read about McConnell's sign. This is a great example of it. You see how here, see how the apex is moving? See how that's coming down right there? And this lateral wall is not moving. So apical sparing is McConnell's sign. Sometimes called an apical wing. So that would be concerned for an infection. So what do you do in the blue protocol? Well, you can look at the legs, right? You can look at the venous structure. Okay? Here's a normal popliteal structure. Okay? See a popliteal vein compressing, right? Popliteal right popliteal vein. What's going on here? Compress. What's going on in that popliteal vein? It's not compressing, right? The patient has an EVT and is setting up a dilated RV with McConnell's sign. That's someone who blood thinners, given how sick I described to you, probably might warrant lytics in that patient. Okay? So that was what I was expecting to see in that patient. However, this is what I saw in this patient. Okay? And when looking at the fluid looked like it looked pretty grimy. It looked like there was stuff floating in the fluid. Sudden onset of chest pain, big effusion, complex fluid. This was a dissection. So we were fortunate to get a patient up to the OR, put on bypass, and able to correct that dissection. So just some example of how ultrasound can really sort of change things in an instant, and that can sort of save your patient's life. So again, I highly advise you just Google, the Blue Protocol by Lichtenstein. A great paper to sort of help you diagnose acute respiratory failure in your whether you're in the ICU, you're on the ward, or in the ED. Very helpful tool. What is the future of point of care ultrasound? The future of point of care ultrasound is now. Okay. So they're talking about using gold record ultrasound in live fluid therapy. Okay. So if you think that giving fluid will help your patient, and you see dry lungs, okay, go ahead and give fluid. If you're seeing B-line, you're seeing wet lungs, our fear with giving fluid is that we're going to put the patient into pulmonary edema and actually decrease oxygen delivery. If you see wet lungs, maybe you should think twice about giving fluids. The reverse is also true. If you have a patient's volume overloaded, you can actually look at the lung ultrasound and gauge the effects of your treatment to see. There's a lot of studies in dialysis patients. They put them on dialysis. They can actually see the water coming out of the lungs, correlating with improved oxygenation. For my intensives out there, they're actually using lung ultrasound to guide recruitment strategies. So they have these very fancy studies looking at lung recruitment with CAT scans. They're doing recruitment tours on the CAT scan table. That's not feasible in my hospital. However, looking at lung ultrasound, they can see these changes in patterns when you go from a consolidation to a B-line with positive pressure. You know that you're both in the lung recruitment. So there's a lot that's coming in the pipe, and this is I think a very promising and a very dynamic, a very helpful tool, whether you're in the fancy intergalactic trauma center or whether you're in a development center. I think this is a great tool if you already have a machine available. Questions?